Concept, a quick and effective manual therapy option. I have had a lot of Zoom meetings by now, but this is the first presentation, so if there's a hitch in the technology, I'll probably seek Britta's assistance. This is very informal, so if you have any questions along the way, feel free to put your question forth and I'll take care of it. Okay, objectives in the Mulligan concept will be Brian Mulligan's influences, Brian Mulligan's discovery, Mulligan theory, Mulligan technique, guidelines, Mulligan technique, and then some troubleshooting with the Mulligan technique. My story is one that I graduated PT school in '98. I went into athletic training school, or got a degree in athletic training, and then went right into PT school. During AT school, I knew I didn't want to be an athletic trainer solely because the hours were so bad. I didn't want to do a bunch of weekends and all evening work, but it really prepared me for PT school. So I went to PT school at the University of Mary, and during my clinicals, I knew I wanted to specialize in spine because I knew I wanted to do outpatient and outpatient therapy clinicals. I had so many back and neck patients that I didn't really know what to do with them. I knew a lot about the extremities and a lot of athletic injuries. However, there wasn't much, if any, spine. I'd worked with men's track and field and basketball and football. Of course, we don't have hockey at NDSU, but I had a great experience. I had a lot of experience treating extremities, wanted more on the spine. So coming out of school, I got a job with Altru at the outpatient department first for a few months. Then I went into outreach where I traveled to some of the small communities. But right away, I started doing spine specialization stuff. I did McKenzie. I started with the McKenzie series and kind of went on from there. I worked for Altru for almost 15 years. I decided to go independent then, and now I currently work at Rehab Authority right downtown Grand Forks. There's 2 physical therapists. We have physical therapy assistant help, and I've been there for the last 7 years. If you didn't notice or read my bio, yeah, I'm certified in McKenzie and Mulligan, so I'm very biased but very excited about the Mulligan approach. This is my wife, Savannah. My little guy, Ari, the 2-year-old. My daughter, Selah. Right-hand corner is our chicken, Sheba. We live out in the country and have 6 chickens. My boy, River. And there's Ari, my 2-year-old. I don't know if any of you have kids, but 2-year-olds are wild and crazy. Can't take your eyes off them, but fun. Now, did anybody see the lecture this morning by Justin Berry? While he was giving his presentation, I shot a text out to his wife to see if I could get some pictures. He's a very good friend of mine. We've spent a lot of time together doing outdoor stuff. He likes to hike and bike, and I do too. There's my favorite Justin Berry picture. High school grad picture, obvious patriot. Very good. This is Brian Mulligan. He was probably in his 70s here. I met him at a master's only class when he was 83, and it's one of the highlights of my career, just meeting this guy who, by this point, I've used his techniques a lot over the years, and I really appreciate what he's done for our profession, done for manual therapy. Of course, his techniques are used across the globe. It was kind of funny. On his way to the course in California, it's so far from New Zealand, and the lady next to him, he thought she had died. He hadn't seen her move, couldn't see her chest move. And so, but he waited till past the halfway mark of the trip, because if he would have said something before that, they would have had to turn the plane around. So thankfully the lady was alive. He's a very, very funny guy, very enthusiastic. He's very passionate still about physical therapy, even as an 83-year-old. Background on Brian Mulligan. From New Zealand, like I mentioned. He went to grade school with Robin McKenzie. father of the McKenzie method. In 39 and 40, he became a physiotherapist in 1954, worked 6 to 7 months, and then decided to open a private practice. Pretty impressive. I know I wouldn't have been willing or able to start a private practice 6 months out of school. Back then, there wasn't a lot known about physical therapy. It was very new in New Zealand, especially. So he and McKenzie worked together and on a couple of ventures in teaching people manual therapy. In fact, he'd go on vacation at times. He would have McKenzie treat his patients, and he'd always tell him, "I'm going to send you to the second best physio in New Zealand." It's pretty interesting considering how well known those guys are. In 1983, he made a discovery. I will talk about that in just a few slides. In 1989, he wrote his first book, and he considers himself to have 3 mentors: Cyriax, Kaltenborn, and Maitland. So I'm going to go into just a few notes on how they influenced Mulligan and what they provided, at least a couple of things they provided to the manual therapy world. Mulligan's favorite quote: "In the field of observation, chance favors only the prepared mind," by Louis Pasteur. There's Cyriax. Cyriax gave us normal versus pathological end feel. Think about the shoulder joint, and if we can move it past too far, we know it's off, or it's too loose, or it's too tight. So just the ability to feel a joint and to know the different end ranges. Is it a soft end feel? Is it a hard end feel? Why is that? Bony end feel? Is it muscular with flexing the knee, like with the hamstring? So that was one thing he provided, and Mulligan was excited about as he had a Cyriax experience. Then we have Kaltenborn. Kaltenborn gave us the dynamic treatment plane. Basically, if we're doing a mobilization, a glide of any sort, we better be changing the direction of our force as the treatment plane changes. And also the concave convex rule. As a review, I'm sure, but the plane passes through the joint and lies at a right angle to a line running from the axis of rotation to the middle of the contacting articular surfaces. So it depends on the direction you're mobilizing it to get the motion you need. So treatment plane moves with the concave joint partner. So you're changing the direction of your force with your glide depending on what position the joint is at. But the reverse occurs with if your plane remains essentially stationary when the convex joint partner moves, as in figure B. Concave convex rule, basically move a bone with the convex surface opposite to the direction of the resisted movement, as that's the way it goes in normal motion, and then the opposite, or you move the bone in the same direction as a restricted movement if you want to move that concave surface on the convex surface. Then there's Maitland. Maitland gave us grades of movement and comparable signs. So our starting position for a joint glide, mid-range of the joint play to the first tissue stop. We know our grades 1, 2, 3, 4, and 5 should be manipulation. And then comparable signs. All good physical therapists are checking cause and effect all the time during treatment sessions. I do this technique, I'm checking to see if it changed the motion. Of course, we want to know what makes the quickest changes, what's actually decreasing their ability to move their joint. Even with exercise, it's interesting, depending on how inflamed a shoulder is, I can do a joint mobilization and my shoulder range of motion maybe gains 20 degrees in deflection. I'll have them do just some internal rotation with the TheraBand and then test it again. If I lose that 20 degrees or it's less now, I know they're not ready for that motion. So it's not just measuring your comparable signs after joint or manipulation or manual therapy techniques. It's also after exercise. You need to know the dose of exercise that joint and or muscle is ready for. But with Mulligan, we're treating joints. Mulligan technique is not for disc work with first spinal techniques. We're working on joints, and we're always checking range of motion and pain. So Mulligan's discovery. So a netball player comes into his clinic. Now this is a sport, it's kind of like basketball, but there's not a backboard. So this particular player jammed their finger, index finger looked deformed, couldn't move the IP joint. He tried traction first, and there was no change in the joint mobility afterwards. Once he held the finger in proper alignment, then had her move her finger, it fixed the problem. He called that initially the stuck drawer analogy. If the joint is off one direction, if you can shove it in the perfect position, then you can move, and then you'll regain function. So that's what happened. And then he just started applying this to all joints of the body, just to see what happens if you shift a joint this way, what happens when you shift a joint that way, what happens if you put traction on a joint while you move it, what happens if you put compression. It's very impressive to me how even with run-of-the-mill, let's say patient lacks internal external rotation, and it's painful with external rotation. What happens if I distract it and then go into external rotation? What happens when I compress it? Often compression of a joint will take the pain away with external rotation. So another Mulligan term is positional fault. So a positional fault exists in a joint causing dysfunction in the form of range of motion loss and pain. Could be acute, subacute, or chronic. That positional fault will continue until the joint mechanics are corrected. As we know, a lot of times joints will correct themselves, but often when people come to see us, it's been weeks or months, and they haven't been able to regain normal function. That's why they're coming to see us. So his techniques are termed MWMs if you're working with the extremities, mobilization with movement, or SNAGs, sustained natural apophyseal glides. So when you think of Mulligan, think of mobilization with movement. You're performing a glide, and then they're moving. Where are they moving? They're moving into their dysfunctional, their place where they're limited or have pain or both, to see if we can correct it. And we know it's happening if the range of motion is improving significantly and staying better. So for assessment with mobilization with movement, if we have just the right amount of force, sometimes you always start with less force than more force, because you can go too far very easily. You can push too hard and it's just going to irritate the joint. So you want to use just enough force to make it pain-free, and you expect an instant result in range of motion or pain, and then retesting, they'll keep the improved motion that we just got from the mobilization. So when I say instant result, of course, if you're pushing on a structure and it's painful, you got to make sure the patient knows, okay, it's the pain you get when you rotate your neck, not the extra pain you're getting right now from me pushing on it. So then the communication comes, that they know what to expect with the mobilization, with the movement. There's also CROCs. So CROC stands for contraindications first. Know your contraindications, the same as with all manual therapy. Be careful of those with rheumatoid arthritis, if you're working with the upper cervical spine. Depending on sensation of the patient, all your usual manual therapy contraindications. I would say I would try Mulligan technique over manipulation. I'll always try the more simple technique first, and then it's like a progression. I'm going to use my next progression until I need to go to a manipulation. So know your contraindications, repetitions, less is better for an irritable joint. For a spine issue, Mulligan would only have you do 3 reps. 3 reps is all you get for visit 1, especially if it's an irritable joint. Often we know that we need to tell our patients, you might be a little sore tonight. It'd be better indication how you're feeling tomorrow, because we are pushing on structures that may have been stuck for a long time and very irritable. So it's going to cause some irritation, and that's okay. But our patients need to know that, because they go home and their neck is killing them. If we didn't tell them that, well, some people will just tell everyone, well, they just made me worse, so I quit going, which is shooting themselves in the foot, because if they just would have stuck with it for a few treatments, it probably would have made a huge difference in their functional ability. And then there's overpressure. Whenever we can do overpressure, we have to use it. And that's the key to lasting success. So we need to give them something to do, but also make sure they're doing it right. Because with any manual therapy technique, I think that's why manipulation isn't always the best course, because it's been proven to be short-term relief. If we can teach somebody to put a joint right and have something to do multiple times a day so that they can put it back themselves, their body's going to hold that correction, and then they'll get better faster. And that's where communication comes in. Patients need to know what you're doing, and you have to give them feedback. Knowledge, know your treatment plans. Every time you're doing a joint mobilization of a spine, you should be thinking about the facet joints. You know, if I'm in the lumbar spine or thoracic, you're changing the angle that you're pushing, thinking about just the best direction to push and force. And the better you get at that, the more, I want to say manipulations, but that'll just occur, and you're not even trying, you're just doing a joint mobilization. But you'll notice the better you get with mobilization, the more that'll just happen. And then you need to sustain the mobilization throughout the entire movement, all the way there and all the way back. Okay, guidelines. If you have the force and direction right in the right joint, it'll produce no pain or very little. We expect significant change in range of motion. Use the minimum force necessary. Sustain the mobilization without restricting movement in both directions. Apply overpressure. Teach self-mobilization with movement or self-snags. And whenever we can, we tape. You know, the beauty of putting a big X on people's backs, whether it's for the lumbar spine or the cervical spine, it helps hold their posture. So if we can maintain the proper position, your body's going to hold the correction and you'll get better faster. But also, just putting tape on people's backs will strengthen muscles, because they're using their postural muscles so much more. We can improve the strength. So I'm a huge proponent of tape, and more so McConnell type tape or Leuco tape, the stiff stuff, versus the Kinesio, which in my mind gives. And again, I am biased. I was an athletic trainer, and when we taped to keep ankles from rolling and wrists from moving. So I've always had a bit of a hard time with Kinesio taping. And I have not been to a course. I've had lectures on it, and I do use it. But most of the time when I use it, I'm using max stretch. Okay. So we want at least one objective sign or a comparable sign before we do things. I'm looking for a shoulder example. I'm looking for which directions are painful. I'll have them lift as far as they can, and then to the pain. And if I can get 3 different things to test, I'm a happy guy. So that might be pain with resistance. That might be range of motion. So there are times when, we need to monitor patient reaction. Are they relaxing for us? If not, we've got to communicate better. But less force is more. Visit 1. Trying to create rapport. Need to sustain the glide while the patient performs a provocative movement. So think about a neck that is painful turning to the right. I'm going to want to glide whichever segment I think it is, and then have them turn. If it's pain-free now and the range of motion improves, I'm on the right segment. It's amazing how I usually, with rotation, I would start higher. I would start at C2. I don't go to C1 until the very last, because if something's going to go wrong, it's going to be messing with C1, meaning causing a headache or a problem. So I'm hoping that correction of C2 is going to fix them. But there are times when I'll check one, no change. Check the next one, no change. Once you hit the right segment, all of a sudden the motion just returns to normal. And it's, again, the name of this is Quick and Effective Manual Therapy Option. It's so nice that you have friends and family coming to you. It's so quick to just try your Mulligan technique, and it takes a minute, and then you can give them something right away. It's not very time consuming. So that's a great reason why to try it. That's why I think we all should know at least a few of these, even if you don't want to ever go to a Mulligan course. All right. So how many reps, how many sets? I'm going to give, after visit 1, maybe 3 sets of 10 reps in the clinic. Out of the clinic, I'm usually having them do it 3 times a day, 10 reps. And keeping proper posture in the meantime, and letting them know what to expect. I'm always telling them, this should improve your motion, make you feel better. You should not have extra pain and be more stiff after this. If that happens, quit, because otherwise you're just making your condition worse. All right, we're done with the boring stuff. So I thought I could see if I can make a video work. So this is the post-boring info video. My 7-year-old is laughing at this morning. I can close our video. How about I get out of here? Okay. Next, I just want to talk about a few techniques just to give you a better idea of what this is all about. So I have some pictures and some descriptions. Oh, how I love to be able to teach the manual therapy part of this. Of course, my favorite part of my job is manual therapy and teaching also. I would much rather do the hands-on stuff. But since this is what we get, I'll do the best I can. Okay, so rotation snags. So I wanted to show you this one just because it's very easy to do, and it's quick, and even without just with a few reps, you really know if you got it right or not. So loss of rotation. So it's usually pain on the side of restriction. So patient seated, your mobilization with your thumb pad, your thumbs overlap on the spinous process above the suspected lesion. Fingers on the mandible or just below. And the only reason for that is to keep their head in a neutral position. Direction. So if this was a right-sided issue, they have pain on the right side, mid-neck, and difficulty rotating to the right, you're going to push towards their opposite eye. So you're on the spinous process, thumb over thumb, pushing towards the opposite eye. Okay. And then the way we provide overpressure is you'd have the patient would move into the right. They'd use their very own hand. You're doing the glide. they're doing the overpressure just to get those few extra degrees at the end and then back. And your job with your pressure, thumb over thumb, is to keep that glide all the way there and all the way back. You don't let up. Here's a picture. So often people think, well, if they're restricted to the right, why don't I want to be on the left side to push it farther over? What's the problem? What's the actual reason for having to be in the same side as the restriction? The thought would be the spinous process has shifted too far to the right. So if I correct that joint mechanic, it restores that segment, and the range of motion coming from that segment returns. So the patient's in perfect posture. Here, my fingers are on the mandible, thumb over thumb on the spinous process. So I'll usually start at C2, but it's very often the most tender segment is the one that needs it. If I regain it all, great, I'll just stick there. But if I regain most of the right rotation, but not all of it, I may check the segments above and below it. So usually when cervical rotation is the restriction, their pain is usually suboccipital or upper neck. If their pain is usually, more around the top of the shoulder, my go-to will be C5. I'll try C5 first because that's most often the one that is the issue. All right. So you can do the same thing with side flexion. So with side flexion, that's the painful movement. They're restricted and or painful going in the side flexion. So it's the same position. Your fingers, if it's right-sided pain, my thumbs are on the right side of the spinous process. My mobilization is anterior and superior, so its pressure is going towards their opposite eye as they tilt. And then the overpressure will be, they'll just grab their own head and go off to the side. That's side flexion. One thing I did want to note with rotation, you need to check rotation both ways after, because there are times when they had normal left rotation before the technique, you do the technique and now they're having trouble going the other way. You need to teach your patients this too. So you can overshoot. You can move a joint too far and regain the motion that was restricted and painful, and then you muck it up going the other way. So the way I'll have patients do this themselves is I'll teach them how to reach over. So if there's a right rotation issue, reach them how to snag that spinous process, that's the issue, and then do their self-mobilization. But I always tell them, if there's a problem, you can't go left, you just go to the opposite side, and usually it just takes 2 to 3 reps, and they regain it. So that does happen. Now, cervical extension snag. So anytime people have pain with cervical extension or restricted end of extension, I'm going to try this. According to Mulligan, it's 80% successful. I feel it's even more than that. If they have extension pain, and it's coming from the joint, because we can have extension pain if it's a disc. Mulligan technique is for joint correction, not disc. Mulligan himself would say that McKenzie technique is the best for disc issues. But when it comes to a joint restricting cervical extension, you can either have your thumbs at the spinous or the transverse processes. Fingers are at the jaw or above. Again, your fingers would be around the jaw just to keep them from losing, going into protrusion. You just want to keep that neutral spine as they go into extension. Depends on their size. A real big person, bigger bone structure, I'll probably be right on that spinous process, or I'll be on the transverse processes. However, a smaller person, I might have to be in the spinous because my fingers are too big to get on their spine. And so your force is anterior superior, but as the neck moves into extension, the facets lie vertically, so you glide up. So you start going forward, and then as they tilt back, you're almost pushing straight up to get the end range. And you'll get good at it. You're trying to keep it pain-free the whole direction. I mean, if they're saying, well, it feels better now, but then it hurts again, you probably need more force, or you need your angle's not right with the movement. So very, very effective. Also, something I'd like to note is there are times it's not uncommon if you have somebody supine and they have pain with extension. Vertigo, faintness, lightheadedness. You're in supine, you extend them, oh, they might get woozy. Now, it's not very often that people will have that happen from sitting. So with sitting, what you do is you put pressure on C2 and then have them do the extension. 8 times out of 10, it abolishes the pain and or vertigo or faintness, all those weird symptoms. I haven't had a patient once that said, hey, that weird eye thing is gone. She didn't even tell me she had an eye thing. But of course, you know, issues with the upper cervical spine, with those nerves going to your face, you can get all kinds of interesting symptoms. Though it's a cervical issue, it's not a BPPV issue, it's not a vertebral artery issue, it's a mechanical issue. So I like to try that first. If they have pain, specifically with extension and seated. Cervical flexion snag, just like a cervical extension snag, only almost 100% of the time I'm on the spinous process instead of the transverse processes. But they have pain with flexion. They have pain and restriction in the flexion, so I'm snagging those vertebrae to correct the mechanics. So Mulligan would say that the spinous process for some reason has been jammed down, so that if we lift it up, that's what corrects the joint mechanics. Hard for me to picture that in my mind. However, it works. Even if, you know, with Mulligan and McKenzie, a lot of their theories, or McKenzie especially, some of the theories have been proven wrong, but it doesn't matter because the treatment is effective and it's been greatly proven over the years. So even if the theories have proven me wrong and we have the right technique to correct what's off, so be it. All right. So with full flexion, the treatment plane is nearly horizontal. So again, we're changing our pressure as they're moving into flexion. Looks like that. So I'm on the spinous here. Looks like I'm more off to the right. I'm trying to be central. Now, if it's equal left and right-sided pain, I'm definitely going to be central. If it was more right-sided pain and pure central pressure wasn't making an effect, I would certainly move off to the left or to the right with flexion. Then there's fist traction. Now, this is 90% successful with mid to end range cervical flexion pain. According to Mulligan, if it's unsuccessful, upper thoracic is probably to blame. So you make a fist, your little fingers at the upper edge of your sternum, your other hand is at the base of the occiput pulling down. And you hold for 10 seconds, 3 times. Looks just like that. So often I don't have patients with mid to end range flexion. It's much more often that extension's the issue. But very simple technique. And it's always sweetest when we can give something to someone that's easy for them to reproduce at home. Moving down to the thoracic spine. So this is restore thoracic flexion or pain with flexion. So the way I'm going to test any thoracic issues, I want to know if it hurts when they breathe. I want to know if it hurts when they rotate. Does it hurt when they flex? Does it hurt when they extend their spine? I want, again, if I can get 3 different things to retest, I'm a happy guy. So let me show you the picture. It'll make more sense. So I am, with my hypothenar eminence, I'm hooking the spinous process, and she's going to go into flexion. I use a little piece of TheraBand so I can hold my grip. Most of the time, I'm going to be on bare skin, so I'm not slipping. So, and I'm always asking, does it feel like I'm in the right spot? Because usually it's the most painful spot. But I'm going to go a segment above and a segment below also to try to make sure that I'm correcting mechanics of whatever segment's the issue. So Mulligan would say that most people with thoracic pain need to be corrected into flexion. Flexion will, if they have pain going into extension, rotation, and flexion is going to be your first course to try to abolish their pain and correct their function. However, starting with Mackenzie first, we're always thinking, we're going into extension first because everything everybody does is flexion all day, flexion all the time. Therefore, we need extension. And so it's interesting, a different school of thought with Mulligan versus Mackenzie in this area. And with the Mackenzie method, we're treating syndromes with Mackenzie method. A syndrome is a collection of signs and symptoms, so it's not just discs, it's joint as well. But if it fits this certain syndrome, then this is the way we're going to treat them. That's Mackenzie. All right. Thoracic extension snag, so it's just the opposite. This is very taxing on a body to do this maneuver, but sometimes it's absolutely indicated and the only thing that's worked. So as you can see here, I have my elbow on my knee. I'm using my fulcrum hypothenar eminence on the spinous process. We're going into extension. A way that I like to do this to help patients in prone, rubber tubing or really tight TheraBand. They'll hold it in their hands and do a press up, and they'll be able to find just the segment that needs to move. It makes the segment pain-free, then you have it, and then just have them rep it out. And I also like to tell people, if you do this, it's a thoracic issue. However, sometimes it really cranks on the lumbar spine. So if that happens, tense your abs. If you tense your abs, that will protect your lumbar spine so that we can mobilize your thoracic spine. And also, if press up is painful or their motion is really limited, the higher you start with your hands under your shoulders, but the farther you move your hands up to do that press up, you'll feel where it's hitting that spot in your spine the most. So you have to teach them how to move their hands up to reach just the position with that tubing in both hands going across their back to be able to mobilize that segment. Of course, ribs are attached there, so it's very tight, and it takes a lot of effort with the thoracic spine as compared to the cervical or the lumbar spine. However, once you get it, it stays put. It's less apt to shift out again. So that's why I think manipulation is particularly effective with the thoracic spine, and not as much with not as much with the cervical or the lumbar spine. Thoracic rotation snag. So it's not uncommon for people to have pain with rotation. So limited range of motion, are painful in their thoracic region. So if rotation is the problem, Mulligan thinks his techniques are better than anything else because you're snagging the thoracic segment, but the way you have your hand is you're also mobilizing the rib attachment to the vertebra. So sometimes you have thoracic pain due to vertebral connections, sometimes it's the rib attachment. And you need to tease that out, of course, but if you can glide both at the same time, great. And you got it if they're pain-free with that rotation. So that's what this looks like. So I'm actually gliding up, and with my right hand, I'm actually creating a bit of traction as she rotates. And if you have somebody to help you to get that end range, that's better. the overpressure. Because again, if they're not going far enough, they're just going to get short-term relief. And so we need to go all the way for lasting relief to correct the segment. And then I did want to show a rib snag just to show you the difference. So you're going to elevate the rib with both hands, and you're moving into the painful direction. Some of the common painful measures, the comparable signs, if you will: deep breathing, flexion, extension, most often rotation of the spine. For palpation, look for the tender rib space. Sometimes it's hard to know which rib is the one that needs it, but just, and I just go multiple. Go with the one you think it is, do the one above and below it, just to make sure. So I'm kind of cupping that rib, if you will, and I'm gliding superiorly, and then I have the patient move into that painful direction. So with this one, it's usually rotating towards me, but it doesn't have to be. Sometimes people will say, oh, it's when I reach forward and it kills me. I'd have them reach forward. You know, often your patients are going to tell you, it hurts most when I do this. Okay, then have them do what's most painful, and you glide them and see if you can take the pain away with that. Then you know you have it. Okay, I put these in here just to prove and to show that Mulligan technique, when it comes to pelvic stuff, is amazing. It's absolutely incredible. And I have had courses on pelvic stuff, and there's nothing that I found that's better than the Mulligan technique. So basically, if a patient has pain with a press up, pain with a leg lift, prone leg lift, and I'm checking that lumbar spine and nothing's changing, I'm doing overpressure, there's still the pain there. Let's say the pain is right PSIS area, and it's not coming from the lumbar spine. I've cleared it. They have pain with lifting one leg. They have pain with a press up. I'm going to see what happens if I move the pelvis. So right now I'm doing a posterior to anterior pressure of the ilium down towards the table, and I'm putting pressure on the sacrum. Now, and then I'll have her do a press up or a leg lift to see if it takes the pain away. Now, if that didn't work, my first change would be on the sacrum. I'd go from nutation to counter nutation and continue to do that PA pressure of the ilium to see if that changes it. Most often, if I'm doing counter nutation, whether I'm doing a posterior pressure or a PA glide of the ilium or the AP glide, that's what's worked best for me. Again, I'm looking at what takes away their pain with a leg lift or a press up. So right here, I'm doing a press up. I'm doing a posterior to anterior glide of the ilium. And you move from unloaded to loaded. So I would do the same mobilization usually from prone to seated. Standing flexion is painful, and then standing. We like weight bearing because we feel if we can do a glide in weight bearing, it is going to have a more lasting effect. How we doing? Okay, my time's about up. So now I'm just going the opposite direction. I'm just going anterior to posterior. Grab that IS, you pull it, and then see what happens. You may need counter pressure. Excuse me. You may need nutation of the sacrum or counter nutation. Have them do the painful movement. Troubleshooting. This has helped me so much in my practice. You look for big changes. If they say, well, I think it's a little better, it doesn't count. They want to feel better. They want you to be successful. But I just tell them it doesn't count unless it's a big change. And so that means we'll be able to know if the motion's changing, but we need their feedback for the pain. And again, you can overshoot. If there's short-term relief, more reps, more force, tape them. Are you making sure you're getting the end range? Go to a weight-bearing technique. All right, so if there's failure to improve the objective sign, a correct treatment plane, correct rate of mobilization, correct direction, how are your skills? Keep practicing. How's your communication with the patient? Otherwise, go to the next thing. That's what I love about Mulligan too. Some gurus will say, this is my way or the highway. You got to use this system. Mulligan says, try it. If it works, great. If it doesn't, do something else. So you can incorporate into anything else that you're doing. That's all I have for you. Thank you for listening. If you have any questions, or do you have any questions? I hate to take up any extra time. All right. I just like to close with, I always open up for students to call me if you have questions about any of the stuff I talk about. So Rehab Authority, Grand Forks, you are welcome to ask me, or if you're in the area, you can check some of this stuff out. I'm always open to have students. A little less likely these days to have students with the COVID stuff, but still I'm willing. Thank you very much.